Hello.
Hi there, nice to meet you.
Nice to meet you too. I'm Jini Mulukutla, and I'm a consultant in liaison psychiatry and psychological medicine, and I'm based in Leeds.
Lovely to meet you, Jeannie. So my name's Isabelle. I'm a final year medical student at Warwick University, and I'm interested in careers in psychiatry.
Oh, amazing. I actually went to Warwick.
Oh, perfect.
many years ago.
Okay. Did you enjoy it?
I loved it. I absolutely loved my 4 years there. I was a graduate entry. I did a degree in physiology and pharmacology at Southampton, but the plan was always to do medicine. And yeah, so I went and did a pharmacology degree and applied to Southampton and Warwick, but actually completely fell in love with the Warwick campus, and best decision.
Yeah, I can understand that journey.
Yeah. What was your first degree in?
I did biomedical science at Liverpool University, and then went straight on to doing medicine at Warwick. And in between times, I worked as a bank healthcare assistant in old age psychiatry inpatient unit.
Oh, that's brilliant. While I was at Warwick, my sort of side job was as a medical secretary.
Oh, wow.
I used to work at University Hospitals Coventry and at Birmingham Heartlands. So that was really helpful actually, because it gave me a sort of a different spin on how hospitals work.
Yeah, I can imagine.
Yeah.
A different side to it, but still very important.
Exactly. Yeah. So, I mean, every single experience I think that you have, whether you're at medical school or pre-medical school, they all have an influence on how you approach things.
Yeah, that's really good advice.
Yeah. I don't know if you found that working as a healthcare support worker in psychiatry has affected how you approach your placement at medical school.
Yeah, absolutely. It's been a really positive experience, both the job itself and actually how it's helped me during placements at medical school. So I feel like I understand how the hospital works a lot better. I have a better understanding of all the different people in the multidisciplinary team, how I fit into that as a medical student, and then how I'll fit into it as a junior doctor. So it's been fantastic.
Yeah, and I think it's so important in medicine in general, but especially in psychiatry, your ability to see things from different perspectives and to put yourself in the patient's shoes, and to really understand what they're going through, what's brought them to that point, that consultation. It's incredibly important for psychiatry. It's the difference between a good psychiatrist and a great psychiatrist.
Absolutely. So what point in your career are you at now?
So I am a consultant. I got my CCT, my Certificate of Completion of Training, in November 2022, and then I had 6 weeks off, and then I started my consultant job at the beginning of January last year in 2023.
Okay,
Yeah.
so you're a liaison psychiatrist.
That's right.
Kind of what's the brief summary of that role?
Sure. So liaison psychiatry actually covers a lot of different things. So liaison psychiatry basically means the interface between mental health and physical health. And so there are some liaison psychiatrists who their role is to help A&E with acute mental health referrals that come in via that route. So people who've self-harmed or attempted suicide, or sometimes somebody who's in the middle of an acute deterioration of their severe and enduring mental illness, but they've presented at A&E or they've presented in hospital.
Okay.
There are other liaison psychiatrists where they do something called in-reach, which is where they visit patients who are having a treatment in the general hospital for a physical health condition, but they either have a chronic mental health problem that the ward would like some advice on, there's a prescribing dilemma, or they've developed some new mental health issues or behavioural issues and they want some advice. Capacity issues come up a lot. Liaison psychiatrists do a lot of work with capacity to consent to treatment and capacity to be in the hospital. So it's a really fascinating area. But the other thing, which is my specialty, is psychological medicine. So that is where we look at physical health presentations and psychological factors together and how they influence each other. So I work a lot with people who have persistent physical symptoms. That means chronic pain, chronic fatigue, things like chronic weakness, where there isn't an obvious medical cause. So conditions like functional neurological disorder or non-epileptic episodes, dissociative seizures. And they can be a really, really tricky thing to treat. a lot of the patients, they have gone through the hospital systems multiple times. They have had some quite difficult encounters with health professionals. So you also have that barrier. They really feel misunderstood. They think that, they have had the experience where their family, their loved ones, people around them, colleagues and health professionals have thought that they've made their condition up. And it can make for a really, really difficult time for them. And some of the patients have incredible amounts of disability, which then becomes a challenge to treat in itself. Yeah. So I work on a small inpatient unit. It's actually the only one in the country, where we help people who've got really high levels of disability, from persistent physical symptoms, medically unexplained symptoms, chronic fatigue, or where they've got a long-term health condition like diabetes, brittle asthma, Crohn's disease, things like that. But psychological factors are preventing them from either being able to engage with the treatment or are contributing to that condition getting worse, or vice versa. That they've got a mental health issue where their physical health state is just a barrier to them getting better. It takes a lot of patience, and I'm incredibly well supported by a full team of healthcare professionals, mental health nurses, occupational therapists, a physiotherapist, dietitian, and psychologists, psychotherapists, and we all work together really intensely to try and help the patient in a rehabilitation way, to try and get back on their feet, or at least turn around the trajectory of their really disabling illnesses.
That sounds really interesting. Sounds like a very important job that you're doing.
Yeah, I mean, it's a very niche area, and I'm really lucky that the journey that I've had in my medical career has meant that I have gotten to this point, because psychiatry wasn't my first choice of specialty.
Okay.
Yeah, so I left medical school never thinking that I would be a psychiatrist at all. But actually, and so I did a couple of different things. But then once I came into psychiatry as a junior doctor, it just really clicked. Yeah.
What was it about psychiatry that clicked for you?
Well, so when I was at medical school, and this was quite a long time ago. It was 2000, and I was at Warwick from 2002 to 2006. And the setup of services then was different. So every consultant in the community had a small number of inpatients, and I just was really unfortunate that my particular consultant that I was assigned to had one inpatient that was too dangerous for students to see. They were too unwell, so I didn't really get the full picture of what psychiatry could do or offer. And it was a rural placement, so often patients didn't turn up to clinic, so I'd drive an hour to a tiny Warwickshire village and there would be no patient. So I didn't really get the most out of it, and I just wrote it off. I thought, oh, well, not for me, many other specialties to try. And then I ended up doing general medicine, sort of in-hospital medicine, respiratory, cardiology, general medicine. I really enjoyed that. And so I thought, well, I like that, so I'm going to apply for that and GP and just take the first job that I'm offered. And the first job that I was offered was working in Leeds in St James's Hospital, in old age medicine. And I got that job and I was all set to move. And my last rotation of my foundation placement, my F2, was psychiatry. And it was completely different. I realised how much time I got with patients compared to the rush of it, the busyness of A&E, or, how a hectic acute hospital ward. I got the time to sit down with people and really get to know them. And I got exposed to a real spread of environments. I got to see patients as an inpatient, in the community, in their own homes, in crisis with a crisis team, in clinic. And the consultant that I was with, she picked up that I was patient and good at just building a conversation. And she's like, you know, if you ever change your mind, just drop me a line and I'll give you a reference. But, you know, because, you know, you'd be a great psychiatrist. And I was like, oh, that's really nice. But I thought, but I've set my career path. But I think it was always in the back of my mind.
Yeah.
And no, I started doing general medicine, and I loved the medicine, but there was a lot, you know, I think there's a lot to do as a medical trainee. Lots of on-calls, lots and lots of patients. And I think because I had psychiatry in the back of my mind, I didn't let myself connect with it fully. I think deep down I knew that you know, psychiatry was probably where I needed to be. So it was at the time when swine flu was a thing, and I got swine flu, and I was lying on my sofa, and I picked up my flatmate's British Medical Journal, thumbing through it because I was bored, and there was this two-page advert for come and join psychiatry in Yorkshire. You know, places available in February 2010 it was. I was like, okay. So I contacted my former consultant, said, did you mean it when you said you'd give me a reference? And she said, absolutely. And a week later, I put the application form in.
Wow.
And never looked back. Core psychiatry training. I mean, it was really full on, but it was some of the best times. Like really honing a craft. That's what it felt like understanding really holistically about people's lives. We covered sociology, health inequalities, in a way that, and you know, psychology, in a way that I don't think any other time of my medical career I got to do things in that much depth. And the core psychiatry training program was, and still is, incredibly supportive and flexible. And so, you know, if I needed, you know, a bit more clinical time, I could say that to a supervisor and go, you know, I feel like I need to know more about this, and they'd help me find the opportunities. Similarly, I want to do, you know, this teaching project, there would be support for it. There was support to fill out the portfolio and support to pass the exams. And yeah, I absolutely loved it from the moment I started. Got involved in all sorts of things. I started working with the Royal College on their Psychiatric Trainees Committee. I did some national projects, and it was like there was all of this support to just let me fly. And yeah, never looked back.
Fantastic.
Yeah.
Your career sounds so varied, and I really liked hearing your journey about how you've got to your consultancy post. So what does a regular day look like, kind of as a core trainee or as a consultant in your current role?
So I'm really lucky that I've got a flexible job plan, and it's one of the nice things about being a consultant is that you can negotiate a working pattern that suits you. So on a Monday is my working from home day, and on that day, because I'm an educational supervisor for core trainees, I use that time to organise my core trainee meetings, to do the admin that comes with that role. I also help to run the Trust's teaching programme with a colleague. So all of the admin that comes with that, the looking at spreadsheets and you know, making sure that each trainee's got the opportunity to meet their portfolio needs through the teaching. So, and Leeds is Leeds and Wakefield is a really big core training centre. So we've got 40 plus trainees. So it's actually quite a lot of teaching to organise. But I love it, and it gives me the time working from home to concentrate on that. And then the rest of the week, I get to work about 7:30, and I get all of my admin, as much as I can, done out of the way before I start clinical work with the patients. And then at 9 o'clock, our team has a handover. And 2 mornings a week are taken up by the MDT, and we have quite an in-depth MDT with everybody contributing. And you know, we'll spend 45 minutes to an hour per week in a team meeting per patient, and we have 8 patients at a time. And then the other 2 mornings are me and my colleagues, my medical colleagues, just making sure that everyone's physical health is monitored, but also a lot of time in interviews and discussions and general reflections with the patient, just monitoring how their responses to the unit, the responses to what's coming up as we're working with them, trying to talk about any potential barriers. And that's really, really important when you're working intensely with people, is you need to spend time with them. And I'm really fortunate that I've got so much time with my patients. It's not enough. I would, in an ideal world, the paperwork would just be, take care of itself, and I'd have even more time. But distance is also important, because you need to be able to step away to get an overview and to see what's going on and absorb all the information.
That makes sense.
Yeah. And then afternoons are taken up by trust teaching programme, supervisions. I have management meetings. The unit's got a long waiting list. It unfortunately suffered in COVID. So one of our big projects is trying to bring that down so that we can help people faster and get, help the people that are, who've been waiting a really long time. And that's the downside of being the only unit that does this kind of work. I've only got 8 beds, and there's a lot of people that need input, with the complex difficulties that they have. So, for the patients who are on the waiting list, and also for patients who haven't yet been referred, I offer a consultation service with other trusts, just to try and help them get perspective on what's going on. Quite often they're not set up for this kind of patient, and it takes a lot of their resource, and more often it's about supporting the team than it is about the actual patient difficulties. It's about how does their system support or not support this patient, and what's the impact of that on them, and then how does that then impact on the patient and the cycle.
That makes sense. So in terms of a typical day as a core trainee, how is that different?
I think, so the biggest thing with core training is you have your clinical job. You also have a resident on call in most places. So that then means that you get taken away from your daytime clinical job. And so you have a portfolio that the college sets for you, and there's a minimum that you have to meet for that. So then you're juggling a lot, doing the academic work and doing the professional things, quality improvement projects, research projects, teaching, that are all part and parcel of every doctor's career, along with trying to learn. I think I used the word craft before, but it does feel like that, like learning, understanding the conditions that you're going to need to understand to keep moving, trying to understand how it works in the system, in the system of the NHS, understanding the academic and the bookwork and the theory behind, why do we prescribe this medication? Why do we use this psychotherapy in this situation? Understanding how it all links together. So there's a lot. I think core training is probably the busiest period of a psychiatrist's career.
Okay.
Yeah, because the other thing that you have to do is pass exams.
Absolutely.
Yeah, so there's a lot going on. Quite often at a time of life when people have a lot going on, people are getting married, people are having children, people are trying to buy houses. Yeah, so it is a busy period, and it's a harder question to answer, I think, than what's a typical day for a consultant, because while a consultant is a little bit more 9 to 5, core trainee can be nights, weekends, as well as the 9 to 5 academic work. So it is much more varied. And for some people, absolutely, they take to it like a duck to water, and other people need a little bit more support. And that's where the role of a clinical supervisor and an educational supervisor comes in, to help be that steady kind of guide as somebody's going through. Yeah, and trying to nurture somebody's individual interests and talents. Some people come into psychiatry with a really scientific academic mind, and other people are very, very, who think much more laterally, and they're all great. They could all have the potential to be amazing psychiatrists, but it's about, as a supervisor, finding what works for that particular person.
Great. So when you see a patient get better, how does it feel and what do the patients tend to say to you?
It is hands down the best feeling. Whether you're working in acute psychiatry or, acute inpatients or crisis or, you're working in community, seeing that progress and being part of that journey, it's just incredible. I think one of the things that was a bit of a myth, definitely a myth, when I was at medical school was it's a group of patients that will never get better. But actually that's actually the minority. And even when somebody has a really chronic, severe and enduring mental illness, there are margins of improvement. Nobody is a write-off. And for some people, it's really easy to get them from, acutely unwell to 100% better. And for some people, getting them from 100% to 70% is a Herculean effort. But every single patient's worth it.
Absolutely.
And when you see that improvement, it gives you all the warm and fuzzies. It really does. And I think for my patients, they can be on the unit sometimes for up to 6 months. So we've spent so much time with them and we've seen them go from disabled to walking or with very little understanding of why they keep repeating behaviour patterns to full understanding that this is something that, isn't their fault or, that they have the power to change when they're ready. Sometimes they're not ready at that time that you're seeing them, but you've given them the knowledge. And patients say, it runs a gamut from, I feel like you've given me my life back to, thank you for opening my eyes and thank you for helping me to see something that I just couldn't see for myself. And it's just the best feeling. Yeah, definitely. It's so rewarding, and it's, my job in particular is like one of those 10,000 piece jigsaw puzzles, the 3D ones.
Sure.
And psychiatry is that kind of specialty. You've got to put the time in, you've got to put the foundations in, and then it builds really quickly. And that's really satisfying. Yeah, it's not for everybody. Some people find it really frustrating that things take a long time. But that's okay. That's absolutely okay. When you're choosing a specialty, I think you've got to think about what suits your personality, what suits your circumstances, and what your friends and colleagues and loved ones are doing. It doesn't matter, it's about what suits you.
That makes a lot of sense.
Yeah.
So how does working with a team actually work in practice?
So when you're in a training position, foundation, core, higher, you spend a set amount of time with a team and you can be really involved, but you and they know that there's an end point. But when you're a permanent member of staff, a specialty doctor or a consultant, you have a certain permanence and that does affect the relationship. And you have ups and downs, like, any relationship, any long-term relationship, it's never always perfect. And, and in a unit as small as ours, sometimes a tricky situation, a tricky patient, dynamics within the patients themselves or the relationship between the patients and the staff can change, and that influences how the team feel about each other. And so sometimes we get on like a house on fire and everything is great, and other times we're sitting in a room and we're like simmering. But we try not to let that stay simmering, that we talk about why it feels difficult right now, what's influencing it. Sometimes it's completely things that are out of our control, but we still try and acknowledge them. And I think that's really important to think about in your medical career. You're not going to get on amazingly with everybody, but you do have the skills to keep it patient-centred. You do have the skills to create boundaries and to make distinctions and still be really friendly. Yeah. You don't want a team that are at odds all the time, but equally, you need perspective within a team. So you can't be super pally all the time either. You have to be able to say to a colleague, that didn't work particularly well. Can we talk about it? And if you're really afraid of disrupting that relationship, to say that, for the benefit of the patient, that's problematic. So, yeah, I think the answer to that is you've got to think about it like a long-term relationship. You will have amazing times, but it's never going to be perfect. And it's really important to talk about when it's not perfect.
Great. Do you feel like you take on more of a leadership role now you're a consultant?
Definitely. It's, even if it's not said out, expressed out loud, it's implied in the role. And a lot of higher training is actually about leadership and management skills.
Okay.
You're learning to take on the responsibility for patients, and in psychiatry in particular, when you're working with the Mental Health Act, you have that legal responsibility as well as an approved clinician. So you have to be able to be decisive and accept that people are going to look to you when things are getting difficult, or when people don't know what to do. And sometimes the answer that you have is, well, I don't know what to do either, but I know where I can go for some extra support, or I know that we need to acknowledge that we're stuck. So the teams that I see in consultation, for example, who are stuck with their patients, who are struggling with a patient with multiple complex problems, the fact that they have said, we're struggling, is huge. Yeah, that means that a consultant in that specialty or that team has gone, all right, team, we're stuck. I'm going to find a way. It might not be with me, but I'm going to find a way. And yeah, so as well as, part of being in that consultant leadership role is also being able to say, no, this is hitting the limit of my knowledge and the limit of my expertise.
Sure.
I'm going to use the skills that I have and the network that I have to try and find a way for this patient and our team. And one of the great things I think about psychiatry is that because it's such a supportive specialty in general, that if I am stuck and I need some extra support from my colleagues in London at the Maudsley, I know that I can say, hi there, can you give me a hand? And they'll help.
Yeah.
And it's because it's not just supportive locally, it's supportive across the board.
That's amazing.
Yeah.
So what's the reality behind making a difference to patients' lives?
I think the reality is it can be a fight, for you and the patient. And it is not, good days and bad days. It's never just a straightforward trajectory. Sometimes the win isn't while you're working with the patient. The win is something that you've set up, or that comes from helping a patient into a system. That sometimes can be, we all have a bit of an ego, and we all really want to be the person that made the biggest difference, but sometimes it's about acknowledging that you or the patient aren't quite in the right place, and that you're helping to set that up. And even if it doesn't go the way you want it in the moment, that you've tried and the patient has tried. Sometimes it is, you never know where the thing that is going to make the difference comes from. And I think especially in my specialty, sometimes, people think that trauma, for example, is something really catastrophic. And sometimes it's not. It's a series of small, repetitive patterns that instilled in somebody something that later was negative, but at the time was protective and helpful. And that's where being curious and being a really, really good history taker, an interviewer, comes out, and why that's really important, because you've got to have enough of a relationship with somebody that you can tease out the nitty-gritty and find these small things as well as the big things. Sometimes patients will wear their trauma and put it down as a gauntlet, and you actually have to get past the big events to find the smaller things. And that's what I think sometimes people, people don't realise. Yeah.
So as I'm kind of exploring a career in psychiatry, I'm quite curious about the extent to which psychiatry is proactively shaping the future through innovation. Can you tell me a bit more about that?
So psychiatry, I think, is at a really exciting point. For many years, the interventions that psychiatry had were a handful of drugs and our therapeutic relationship with patients, our interview skills, and those are still absolutely really important. But as technology develops, there's so many different things going on. For example, radiology, the increasing use of things like PET scanning, and how that's giving us more and more information about the brains of people who are suffering serious enduring mental illness. And at the moment, we're still not too sure what to do with that information, but we will be. We'll get there. I think other things are, there's been some really interesting developments with medications. We're looking at different medication targets. There was quite recently, novel antidepressant in the form of ketamine use, which still is in its infancy, but is a really interesting avenue to be exploring. There's increasing research in the use of psychedelics in treating mental illness, and we're still so early in that. We have no idea how that's going to play out, but it's really exciting to know that the research is out there.
Absolutely.
Yeah. And constantly, whether it's medication, investigations, or psychotherapeutic techniques, there's constant innovation. It just perhaps doesn't look the same as acute medicine or acute surgery.
Do digital kind of innovations have much of a role in your day-to-day job?
For me personally, it's not a huge part, but it is a really exciting area. I have friends and colleagues who are exploring the use of artificial intelligence and app-based programming to help patients on a more day-to-day level. And I think that's absolutely fascinating because that is something that people are using day to day and more. And I think it's right that we should be trying to harness it, and try and make it work for our patient group.
Absolutely.
Yeah. Is it right to ask you something?
Of course.
So we were talking earlier about myths, and especially the one about patients don't really get better, and I was hearing that 20 years ago at Warwick. What kinds of things do you hear about psychiatry as a medical student, currently?
That's a really good question. I think there's still kind of a general feeling that patients who access psychiatry services, there is difficulty treating them, and you might come across social problems, which might also be difficult to treat in your role as a psychiatrist. However, to counter that, I found through my placements and from actually talking to people like you who are doing the job, that because it's such a team-based specialty, you do have people who are trained and who are qualified to help tackle all the different problems that do come up. And although there are some very unwell patients, people do tend to get better, and I'm sure that is a lovely thing to see in your day-to-day practice.
Yeah. One thing that was taught to me when I was in my core training was the population of mental health patients. There's about a third that you'll only ever see once in your career. Like they have a problem, you help them with it, and they're sorted, they're back on track. And then there's about 1/3 who you might see a handful of times in their lifetime with the same problem. And then there's about 1/3 who they have good periods and bad periods, but they always live with a modicum of mental disorder. Every single patient has the potential to get better. Where that point is varies. Some people it's 100% recovery. Other people, it's a little bit of a problem, but day to day, it doesn't bother them, and there is a group of patients who will always be affected in some way. And one thing that we still don't know, and would be a great research area, is to find out what differentiates those people. The answer is it's probably many, many things. It's multifactorial. I think it's a real concern about I think that concern about social problems is really valid. We do live in an unequal society, and that feels more acute at the moment. But part of being a psychiatrist is you don't sit as, one specialty completely, in isolation. You sit within, a hospital system, a trust system, the NHS, and you also sit, within a social care structure as well. And nearly every psychiatrist will have to work hand in hand with councils, social care services, to get the best for patients. Indeed, social workers are an everyday part of working in mental health services. For example, when you're working in the Mental Health Act world, right next to you as you're assessing a patient is a social worker, the approved mental health social worker, approved mental health practitioner, who actually is the person that makes the decision about a Mental Health Act assessment. So, yes, social care and social problems are part of it, but part of the role is working with that. Yeah. We don't say goodbye to the patient at the hospital door. We make sure that we understand where they're going and what systems are there to support them when they leave your service. Yeah. Are there any other preconceptions that you had about psychiatry before you became a medical student?
I think I always imagined psychiatry, before I had any exposure to it, as quite a solitary specialty, where it would be kind of patient and doctor alone, the doctor making all the decisions, and it being quite authoritative. But I'm really able to see now that that is not the case, and if you could tell me a little bit more about why that isn't the case, I think that would be really helpful.
Yeah, it's very, very unusual that a patient wouldn't be involved in their decisions about their care. Psychiatry is probably one of the most patient-centred specialties, and even, if a patient is detained under the Mental Health Act, you're constantly working towards a path of them coming out of hospital, back into society, back into the world, and you can't do that without their input. And it is, as you already said, a real team effort. The medical side of looking after somebody is only actually a small part of it. It's about supportive nursing. It's about helping people back with their function, so that's occupational therapy. In the case of my team, working with patients who've got disabilities, physiotherapy is a huge part of that. And every single role is as important as each other. As a cohort of core trainees, you work together constantly, whether it is on a research project, whether it's on call, whether it's doing a teaching project together. You're constantly working with colleagues at the same stage, or at earlier stages, or at later stages. And it's really, you're all working for the greater good of a patient or a group of patients. And that really unites you. I'm still, some of my best friends are people I did core training with. And despite the fact that we're spread all over the world now, we're still, amazing friends, because it's, when you go through that, that learning, those clinical roles, that development, it's such a bonding experience. And equally, the teams that I worked with in core training, I still see, I work in the same place that I did core training in, and people remember you, and people remember patients that you shared, because it's more intense in a way, because you're not just working to treat somebody's medical problem, you're working to get somebody's life back on track. And that there's nothing that bonds people together more than that united goal. Yeah. So I actually think I feel I think I felt less isolated when I started core training than when I was doing core medical training, and was the only doctor at night, walking through the corridors of a really, really big hospital, compared to core psychiatry training, where there's 3 or 4 of us core trainees looking after all the different services in the city overnight. So, definitely not my experience that it was solitary.